starting in 4 minutes. At 7 p.m. we'll start, 7 p.m. sharp. Till then, please stay logged in and we'll start soon. Okay, hello friends, welcome to Health, Music and Fitness channel, and today we will be learning about ECG again, and today is the third lesson and third live stream, and we'll be advancing more and more as we progress, and more complicated ECGs and conditions we'll discuss. And just to start the lecture, we'll just recapitulate like I always do. We'll revise what we learnt in the previous class, and that will help us in making an association of the previous lecture with today's lecture. Today's lecture is very short. It is on conduction blocks, and conduction blocks basically will be talking about left bundle branch block, right bundle branch block, and left anterior fascicular block, and left posterior fascicular block, and bifascicular blocks. So it's a very important topic, and we'll start soon. Okay, so we'll start the class today, and to begin with, you know, ECG, and we always talk about this circle, and we have to always come back to this circle again and again, because the whole of the ECG, the secrets of ECG are in this circle only. Okay, and it's a very nice thing. The whole of the electrical voltage system and the conducting system and all the leads and how the conduction spreads from one place to the other in the heart, it's all described very nicely, and we can plot the leads, and you know, the lead 1 is at 0 degree positive pole of AVF is at plus 90, and positive pole of lead 2 is at plus 60, of 3 is at 120 degrees, and AVR is at minus 150 degree. This is the positive pole of AVR. Okay, and this is the negative hemisphere, and this is the positive hemisphere. And we also discussed about rate, rhythm and axis. I don't know why there is so much of delay, there is buffering. So now I can see all of you joining. Welcome Rohan, Sankavi, Indu, Kalashna Kumari. So I hope I pronounce it right. Anushka, thank you all for joining, and please inform your friends also. We are revising for 5 or 10 minutes. We'll revise, and then we'll start the actual class of today, that is conduction blocks. So I was talking about the positive poles of these leads. AVL's positive pole is at minus 30 degree, and then if there is a positive pole, there has to be a negative pole also. Okay, so 1 is at 0, so the negative pole is at at 180 degree. AVF is at plus 90 positive pole, negative pole of AVF is at minus 90. Okay, so cut short, then we discussed about the quadrants, we discussed about the axis, rate, rhythm, you know, and we discussed about the quadrants. And this is the normal quadrant from 0 degree to plus 90 degree. This is the normal quadrant electrically, and from clinical point of view, many cardiologists, many authorities, they take up to minus 30 degree as normal and up to plus 120 degree as normal. Mufsina, Ranjana, welcome. So so the normal quadrant clinically is from minus 30 to plus 120 degree, but electrically we'll talk about electrically only, and it is from 0 to plus 90 degree. That is the normal quadrant. Left axis deviation will call when the axis is between 0 to minus 90. Right axis deviation when the axis is between plus 90 and 180 degree. Then we will have extreme rare condition like congenital heart disease, very bad COPD. In these conditions, you will see the axis will be between minus 90 and 180 degree. So that is extreme rare condition, and sometimes you will see axis in that area also. So in that case, what will be lead 1 and AVF looking like? Lead 1 has to be negative, plotting here. AVF also has to be negative, plotting here. Then it will be in this quadrant. Okay, so you have to remember this. And we also discussed for AVR all the normal complexes are inverted. P is inverted, QRS is inverted, T is inverted, because all the impulses are going away from AVR. AVR is out here, so you imagine SA node has fired, and impulse is always going like this away from AVR towards lead 2. So for lead 2 is very happy. She is getting she or he is getting lot of positive impulses. So there is a positive P wave, positive QRS, and positive T wave. For AVR, everything is inverted because AVR is unhappy that the electrical voltage is going away from AVR. Okay, then 3 is sort of looking like this. Okay, the impulse is coming like this and going towards lead 2. 3 is out here at 120 degree. So 3 is happy for some time. Impulse is sort of coming towards lead 3, and then it is going away from lead 3 when it is going towards lead 2. Okay, so 3 is looking like this. Impulse is coming. 3 is happy. R wave is forming. Then it is going away little, and S wave is forming. Okay, so lead 3 will have a small S wave also. So like that you have to imagine. And because the impulses are coming towards lead 2, all the impulses are complexes are very nicely formed in lead 2. P will be good, QRS will be good, T will be good. Then we discussed about some more people have joined. Welcome Nazima, good you made it, your net was not working I heard, and Sanjana Lokhanwani, great. So so this is about axis, okay, and wherever the impulse is going towards the positive pole of any of the leads, it will be perceived as a R wave, simple as that. And let us say in lead 1 you are looking at the ECG like this and you see a good R wave, so means the current is going towards lead 1, and then you have to think all like current is going towards lead 1, basically away from lead 3, away from AVF, okay, it's like this. So current cannot go like this, it will go either like this or like this. So if lead 1 has a good R wave in first lead only, first lead is lead 1 in the ECG. If lead 1 is very positive, AVF you can expect to be negative, it can be positive also, it can be negative also, okay. So axis will be around 0 degree only, because lead 1 is at 0 degree. If there is a very good R wave in lead 1 and no S wave, because then the current is directly going towards lead 1, and then axis can be 0 degree, 10 degrees, 20 degrees, 30 degrees, and for that we discussed the tan theta method, and tan theta method will with that we can directly and accurately diagnose, calculate the axis up to few degrees changes. One of my seniors, my teachers used to calculate calculate the axis using tan theta method, and since then I was very curious how is it and how we use it, and anyway we came to know and I have taught you, so we can bypass these. So SA node is the fastest firing pacemaker, and then is the AV node, and heart has to sustain life, okay. So if SA fails, the atrial pacemakers will pick up, and if they fail, the AV node will try to pick up, and otherwise the ventricular ectopics, the VPCs will pick up and try to sustain life. And in junctional escape beat, like in AV node is there, it is firing, sometimes it backfires towards the P wave. So AVR will become positive, the P in AVR will become positive, okay. So like this, I will come to detail in next slides, next lesson lecture maybe, okay. So fascicles we have done, QRS we have done, we will just have a look at these slides because these are important, okay. So AVR everything is inverted, SA is out here, it has fired like this, AVF is very good P, very good R, very good T, and lead 3 is little small r, because impulse is coming towards lead 3, then it is going away while it is stimulating the lead 2, okay. So 3 will have a small r and a small s also, okay, and it's like that. Then so then also you have to remember this V1 V2, they will look at this part of the right ventricle, okay. So V1 and V2 they don't cover the whole of the right ventricle. So V1 and V2 will cover only that area where I have drawn V1 V2, rest of the right ventricular area is outside the domain of V1 V2. So that you will see in V3R and V4R. So you will plot the ECG electrodes like this, V1, V2, V3, V4, V5, V6, and to see the right ventricular infarction or right ventricular changes, you will see right sided leads. So V2R, V3R, V4R, V5R, V6R. So V3R and V4R are very important for right ventricular changes, and in V3R if there are changes, ST elevation is there, like that is diagnostic of RV infarction, and it carries a bad prognostic sign. These patients can go into cardiac shock and cardiogenic shock, and you should avoid nitrates and dopamine and all these drugs, because they can precipitously fall the BP. The BP will crash suddenly. So Purkinje system, I told you, Purkinje system is like the lighting system, like on Christmas and on New Year, like you see the lights are hanging on your outside the house, but when you switch on, all the lights they will light up together. It's not like first strip of the bulb will light up, then the second, then the third, they all light up together, okay. So Purkinje system innervates the myocardium in such a way that in a very systematic way the myocardium contracts, and it is a squeezing rotatory movement of the myocardium starting from the apex till the base, okay, so that the blood is pumped into the aorta and from the right ventricle into the pulmonary artery nicely, So it's a very dance like movement like this. So if you do the echo, on the echo you can very nicely see. And the current in the myocardium, it will go from transmurally. Let us say this is the left ventricular section, hemisection, cross section. So this is the LV cavity. So the current will go like this, not through and through like this. Okay, so transmurally it will go from endocardium to myocardium to epicardium. Okay. So this we have seen, and I will just rush through. So sometimes you will ask, where is the P wave repolarization? P wave repolarization you will not see in the ECG, because at that time the LV is depolarizing and the left ventricle is very bulky, because the left ventricle has to pump the blood into the whole of the body. So it is very bulky, muscular, and it overpowers the overpowers the atrial activity. So you will not see the atrial repolarization in the ECG. Then what is a normal sinus rhythm? You know, normal sinus rhythm, like it starts from the SA node, a good looking P wave. In all the complexes the P wave is similar, regular, and maximum height of the P wave is less than 2.5 millivolts, and it is best seen in lead 2 and in lead 1. In V1 it is biphasic. In V1 P wave is biphasic. Okay, the positive component of P wave in V1 is right atrium, and the negative component of P wave in V1 is left atrium. So if you want to comment on the atrium, left atrial enlargement, right atrial enlargement, or biatrial enlargement, like in dilated cardiomyopathy, you look in lead 2 and in lead V1. Okay, in lead 2 you might see a broad P wave, which means, see in V1, in lead 2 P wave is like this, symmetrical normal P wave. Okay, now let us say this is the right atrium till here, right atrium, then from here left atrium. Okay, ECG is going like this. So P wave, QRS, T wave, P wave, QRS, ST. So right atrium, from here left atrium. So this is the P wave. So now let's say the left atrium has enlarged or dilated. So P wave is forming, the right atrium has formed, its complex is part of the P wave, then the left atrium is dilated, so it will take more time. Okay, so you will get a bifid P wave. So yesterday Dr. Javed had asked actually, and I was not looking at the comments because Eric was not with me to help me with the comments and all, so I didn't look at the comments. So that is in biphasic P wave. So biphasic P wave you will see in V1, and the negative component, if there is left atrial enlargement, the negative component of the P wave will be more prominent, very deep, and in fact sometimes you will not see the positive component at all in left atrial enlargement. So that is important. So okay, so we will rush through these. So you have to remember, LV dominates the electrical activity of the QRS complex in the ECG. There is right ventricular also, which is contributing electrically, but left ventricle is very powerful. And if there is any type of block, now we are going into today's lecture, and if there is any type of block arising from the left ventricle or in the left sided conducting system, it is very, very pathological, it is very, very organic, and it is functionally very detrimental. Okay, let us say patient develops a left ventral branch block, it is very bad, it is organic, and or left anterior hemi block. So these blocks you have to take very seriously. On the other hand, if the patient develops right ventral branch block, that is not a good thing, but in many of the COPD patients you will see the patient has right axis deviation and the RBB also, but the patient is asymptomatic, and that is because of the there is a right ventral branch in COPD, and usually nothing has to be done. But if there is a LBB, you have to diagnose, you have to investigate, you have to do his bundle studies and electrophysiological studies if need be, and coronary angiogram, you have to do the echo, and you have to do TMT. And always remember, if you have to do treadmill test, TMT test, always do an echo before you do the TMT, because there are certain conditions in which you should not do echo, you should not do TMT, and things like dilated cardiomyopathy, you should not make this patient run on the treadmill when you know the ejection fraction is 22%. You should not make this person's heart stressed by making him run on the treadmill. Okay, so that can lead to death or fatal arrhythmias, ventricular tachycardia and things like that. And HOCM, hypertrophic obstructive cardiomyopathy, in this also you should not do the TMT. And so you have to do the echo first and then you decide to do TMT. But the diagnostic test to rule out any coronary pathology is coronary angiogram. Okay, see, your ECG can be normal, your TMT can be normal, your echo can be normal, and still the patient's all three major blood vessels supplying the heart can be blocked 99.9%. If the patient has developed collaterals, he will not have any sign symptoms, but suddenly he might land up with MI. So you have to be very careful. You should do an coronary angiogram whenever you get a feeling that this patient has a cardiac problem, serious cardiac problem, but his ECG looks normal, TROP is normal, echo is normal, but I feel this patient has a cardiac problem. Go ahead, do the do the angiogram and get done with it. If it is there, good. If it is not there, very good. Okay, so like that. Then interventricular septum, I told you, from left to right depolarization. When left to right depolarization is happening, V1 records a small r. Now remember that circle out here. Okay, V1 records a small r. At the same time, V6 is recording a Q wave in Q wave. So similarly, then impulse goes to left ventricle, R wave is forming in V6, and then in V1 an S wave is forming. So I think we can bypass the rest of the thing. Okay, we'll just see the transition zones. So then R wave keeps on progressing from V1 to V6, keeps on becoming tall and tall and tall, and till V5 it is progressing. Then V6 R is slightly less than R of V5. Okay, and there is a transition zone where R becomes taller than S, that is between V3 and V4. In counterclockwise rotation, looking from the patient's foot end, the heart will rotate like this electrically, and the transition zone will shift to V2 and V3, or V1 and V2 between. And in clockwise rotation, from V3 and V4 to V4 and V5, or V5 and V6. So these are different causes. We will not go into these details because we have already discussed. If you want to see, you can refer to the yesterday's live stream, and it is still there on the channel. So always rate rhythm axis, axis we have done. We will not spend time on axis. So okay, so T follows R, Qt is inversely proportional to heart rate, V1, V2 oppose V5, V6, inferior leads oppose lateral leads, because current can go only in one direction. Okay, and tallest R is the axis if 1 and AVF are positive. So you remember this, and most of the things you have done, then your basic homework is done. Okay, so okay, now we will do. Okay, so today's lecture is very short, and we will be discussing conduction blocks and coronary artery disease. So mainly, you know, from the circle, the impulses arise from SO node, they fire and stimulate the atrium, then the impulse reaches the AV node, bundle of phase, there is a small delay, and then there is a left bundle branch and a right bundle branch. Left bundle branch divides into left anterior fascicle, which lies superolaterally, and left posterior fascicle inferiormedially, and right bundle branch supplies the right ventricle. And there can be a septal branch arising from the left bundle branch, left anterior fascicle, left posterior fascicle, or a combination of these, and it supplies the interventricular septum from left to right. So this much you have to remember. And if there is a block on the left side, LBB, LEHB, or LPFB, these are serious blocks. Okay, you have to investigate actively and not waste time. Don't think, okay, this is just normal, patient has blood pressure, so he has a LEHB. So you should evaluate. Now, what is intrinsicoid deflection? This is something which most people don't even think of it when they are looking at the ECG, and this is a very subtle sign of a patient developing a conduction block. Patient developing, like you can actually profess, you can guess that this patient will develop left anterior hemiblock, or this patient will develop LBB just by looking at the intrinsicoid deflection. So it is very important that you should know this is the intrinsicoid deflection from the starting of the R wave or the Q wave to the tip of the R wave. So this is where the ventricular depolarization starts. Okay. So normally it is 0.45 milliseconds, and if it is more than that, it is increased VAT, ventricular activation time. We call it increased ventricular activation time. So now see, in this complex, it's like this, very symmetrical R wave, tip from tip it is coming like this. Okay, this is normal. In the other complex, you see where R peak time, there is 2 R notches. So the VAT is increased, ventricular activation time is increased. So instead of R wave being like this, it becomes like this. Okay, so there is a more incline at the upstroke. So this is called intrinsicoid deflection, increased VAT, and it precedes formation of left ventral branch block, or interventricular conduction block, or left anterior hemi block, or left posterior fascicular block. So you have to look at this finding very intently. Now this is again, it reflects the ventricular depolarization from endocardium to epicardium. Now this is VAT from here till the tip of R. Okay, so this is what VAT is, increase ventricular activation time. Now out here VAT looks okay because it is symmetrically going up and symmetrically coming down. When the angle of the R wave going up is steep like this, and then it comes down like this, this is increased VAT. Okay. So this we have already discussed. Left sided blocks, you look at the VAT, ventricular activation time, it is increased or not increased. Okay, and they will signify of a coronary artery disease or a sclerodegenerative disease of the conductive system. Okay, so this is again intrinsicoid deflection. So it is more than 0.45 seconds. So this is intrinsicoid deflection, and more than that is pathological. Then you will say VAT is increased. Now I said ki if something is positive very tall in V6, negative will happen in V1. They oppose each other. Something positive in lead 1, negative happens in AVF, because current goes either like this or like this. It cannot go like this. Okay, from V1 to V6 it cannot go like this. It will go like this or like this. So I am trying to make it very simple. So some more people have joined: Ankita, Ashwarya, Ritu, Bushra, Mahesh. Thank you guys, and hope you guys are benefiting from these lectures. And now you see, this is left bundle branch block. Now see, in left bundle branch block there is a right bundle branch and a left bundle branch for 2 chambers. Now we have blocked, where is that square circle? So this is the left bundle branch. Now let us say we have blocked it out here. Now the left ventricle has to get stimulated because LV has to pump blood into the aorta. So then the current comes from the right bundle branch. Okay, so this is the right bundle branch. So it will go like this and into the myocardium, and then it will stimulate the left bundle branch. So it is from one chamber to the other chamber. So QRS widens. So this is true for right bundle branch block and left bundle branch block. QRS is broad. It is more than 3 small squares. So 3 small squares are 0.12 seconds. Okay. Now see, we have blocked the left bundle branch. Now current is going like this towards lead 1. Okay, so lead 1 is becoming positive, positive, positive. Just plot it positive, positive, positive. So I said if lead 1 becomes positive, without thinking place AVF at -90. Okay, AVF is negative, negative, negative. So left bundle branch block, left axis deviation in this quadrant from 0 degree to -90 degree. Okay, this quadrant, your axis is lying here out here, and there is broad QRS, and you look at the, I will show you the ECGs after some time, and in that you will see there is ST depression with concavity efforts and T wave inversion, and tall R in V1 V2, V5 V6, deep S in V1 V2. So that is a complete criteria for left bundle branch block. So I said left sided blocks, they dominate the electrical activity. So even if there is a right bundle branch block, that will still show a LED. This is what I meant. And sometimes there will be RBB and LAHB, and axis will be left axis deviation. So that is why left sided activity dominates the right sided activity. Hi Gurpreet, welcome. So now we'll see some ECGs, and just look at this ECG, guys. Spend 2 minutes on this, then I will ask you. You can type in the comments what you see. You have to calculate rate, rhythm, axis. Just tell me this. Nazima, just calculate the rate. So rate you will calculate. I think I didn't tell you about how to calculate the heart rate, but I know most of you know it. So 1500 divided by number of small squares, or 300 like 2 RR intervals, 300 divided by number of big squares and between 2 RR intervals. So that will give you the heart rate. So what is the heart rate in this ECG? I know this is a complicated ECG because there are a lot of ectopics happening. Okay, so okay, you may skip the heart rate. So roughly the heart rate might be around let us say 75 beats per minute, but there are a lot of ectopics. This is a difficult question. So anybody? Dileshwar. Okay, so this is a ECG of a patient who has left bundle branch block. So now because the left bundle branch, you remember the circle again, the impulses are coming towards lead 1, because the right bundle branch is sending the current towards left ventricle. Okay, so there will be a small R in V1 because the left heart is becoming more and more dominant, and there will be tall R in V5, V6, and because of that there will be a small R in V1. Okay, so that is important, and V1 and V2 I told you they oppose V5, V6. Now in this ECG there is something very interesting. Now see, whenever the patient comes to you with left bundle branch block and patient has not feeling comfortable, see, LBB won't make you feel uncomfortable, you won't become dyspneic. So Lokanwani says RSR pattern in V1. No Lokanwani, no, there is only RS pattern, and I will tell you why. Anybody else? Till then I will tell you what is more very occult in this ECG. See, the patient with LBB, he will not have chest pain, he will not become dyspneic, he will not have frothing and all those things, signs of left ventricular failure. LBB can be there silent, just like a RBB. But if a patient develops a fresh LBB, okay, or a patient has an old LBB, he was stable and now he has breathing difficulty and all those things, chest pain. So, but TROP-T is negative, ECG otherwise looks normal. So, this patient has MI. 99.99% of the times this patient has MI. LBB is not a joke, and if it is suddenly occurring, patient is not comfortable, treat as MI. Okay, now you look in this ECG. The complete criteria for LBB is L for left, L for left bundle branch, or L for LAD. Okay, left axis deviation, broad QRS more than 3 small squares, ST depression with T inversion, and there is concavity upwards ST depression. Okay, and there will be tall R in V5, V6 and reciprocal deep S in V1, V2. Now see, deep S is forming in V1, V2, and then what it means is electrical impulse is going away from V1, V2. That is why there is a deep S forming, because V1, V2 is not happy, current is going towards V5, V6. Okay, so the R wave amplitude will decrease because the current is going away from V1, V2. Okay, so it doesn't mean that the patient has some anterior wall ischemia. He can have, it's a tricky situation, we will have to repeat the ECGs, we will have to do the echo. Okay, so merely because of LBB, the amplitude of the R wave in V1, V2 can diminish. That is what I want to say. Now you see in V5, V4 T is upright, it should be down. V5 T is upright, it should be inverted. Even in V6, ST is depressed, T is upright. Okay. So, this is called concordant T wave. This is a sign of MI. This patient has anterior wall or lateral wall MI, and he is having so many ectopics. This patient is throwing so many ectopics. Now, you see how you will look at the ectopic. See, this is a normal LBB, normal QRS, P, QRS, T. This is the complete criteria for LBB. Now, before this complex, there is probably no P wave. Okay. There are a lot of ectopics. This is an ectopic, there is no P wave. This is an ectopic, premature ventricular contraction, there is no P wave. Okay. And it should have occurred out here, it has occurred prematurely. So, we will call it VPC. And if more than 3 or 4 VPCs are happening in a row, the couplets you are seeing, it is a dangerous situation. You should control the ventricular rate with Cordaron or metoprolol or something. Leave that to your cardiologist, let him decide. But you should have this thing in your mind, like if the person is throwing multiple VPCs, multiple ectopics, supraventricular or ventricular, you should probably start beta blockers or some cardioactive drug to control the ventricular rate, because suddenly this patient can throw a VT. And always remember, if the heart rate is, see, normal heart rate is between 60 to 100. Okay. If it is more than 100, it can cause any type of tachyarrhythmia or a bradyarrhythmia. Okay. Let us say the tachyarrhythmia has occurred and atrial flutter is there and heart rate is very fast. AV will block, AV will cause 2:1 block, 3:1 block. That is a physiologically required block which the AV is doing. Okay. Now, there is a, if the heart rate is less than 60, it can suddenly cause R on T phenomena, and suddenly some ectopic can land on the T wave when it is repolarizing, and then the VT can start. So, brady can cause VT, tachy can cause VT, and blocks also. Okay. So, heart rate has to be within normal range. Now, look into this ECG. Now, this ECG is, anybody please look at the ECG, Lukanwani, Dileshwar, Nazima, Sankavi. Please comment in the box so that I know you people are understanding, because otherwise it feels as if I am talking to the laptop. So, you calculate the rate, rhythm, axis. Never bypass these 3 steps. Now, you see in lead 1, there is a positive R wave. Okay. So, positive R wave means axis is around 0 degree. In lead 1, R is positive, there is no S wave. So, axis current is going towards lead 1. If you got this, you have understood the ABCD of ECG. Then nobody can touch you, nobody can fool around with you in the ECGs. Okay. So, axis is around 0 degree, it can be minus 30, it can be plus 10, it is somewhere around there. Okay. So, lead 1 is positive. Now, you look in AVF, AVF is negative, I would say. Okay. And then anything else you have noted? You see out here the P wave, it is good size, but it is broad. Okay. It is more than 3 small squares. So, P wave is broad. And now, to confirm, this is lead 2. Now, to confirm whether we are thinking nicely or not, rightly, you look in V1. In V1, P wave has to be biphasic. So, Indu says heart rate is 75. So, 1, 2, 3, yeah, roughly around there, slightly more than that, because 4 squares will make 75. Okay, fine. So, for me, if the heart rate is, if there are 3 small squares between 2 RR intervals, I am fine. The heart rate is between the normal range, and there it is less than 5 small squares or 6 small squares, it is fine. So, heart rate is within normal range. That is how I think when I look at the ECG like this. By then, my brain has registered and calculated the heart rate and the axis, like lead 1, 2, 3, AVR, AVL, AVF. Then I look at the Q waves, the VAT, progression of the R waves, and the transition zones. Okay. So, like that you have to program your mind when you hold the ECG rhythm in your hand. So, there is, so Dileshwar says there is tall R in V5, V6. Okay, first we look at the calibration, calibration is normal. Okay, yeah, and Then in V5, see R wave is tall, okay, there is hardly any S wave. Now to confirm whether we are making a right calculation or not, you look in V1, V2, there is a deep S, okay, there is a deep S in V1, V2, very good, Amritya Paul, so very good. So V1, V2 I told there oppose V5, V6, V5, V6 opposes V1, V2, tall R in V5, V6, deep S in V1, V2, it's like a dance, tall R in V1, V2, deep S in V5, V6. In our right middle branch block we will come to that. There will be tall R in V1, V2, deep S in V5, V6, same electrical funda. Now in this ECG the current is going towards lead 1, okay, towards lead 1 like that. So V1, V2 are sad, so they form R wave, S waves or Q waves if there is an MI. So now you might say, sir, this looks like a Q wave, okay. So out here this is a Q wave, okay, this is slightly, there is a slight nudge. I would take this as a, some cardiologists might say this is a Q, some might say this is a R wave, RS complex, but out here see there is a small nudge, you have to zoom and see this is a R wave probably, okay, and out here see there is a small notch and then there is a S wave. When this is clear, it is going like this and coming down, then it becomes a Q wave, okay, but definitely the R wave progression is not there, okay. R wave I cannot see, and it would be okay to consider old enteroseptal MI because V1 to V3. We will discuss myocardial infarction tomorrow, not today because it is a very long lecture, and maybe tomorrow we will discuss, okay. And so V1, but you should know this is probably this is a Q wave or a R wave. Yes, out here it looks like a R wave, here also R wave, and some other complex, this is also R wave, okay. So let's label it as LBB, complete LBB. So broad QRS, more than 3 small squares, and all the criteria for LBB are there. What else are you seeing? So let's come to this P wave again. Now look in V1, the P wave is biphasic, this is small notch, that is the right atrium. The rest of the area of depolarization of atrium has been overpowered by left atrium. The negative component of left atrium is very prominent. You can say P is inverted in V1, okay. So that is left atrial enlargement, and always remember, you never say left atrial hypertrophy, you always say left atrial enlargement, left atrial dilatation. The current in atrium travels sort of like this across the wall, okay. In the myocardium it is transmurally, through and through, from endocardium into myocardium into epicardium. So that is very important, okay. So there is a left atrial enlargement. Now you should think why there is a left atrial enlargement. There is a lot of pressure in the LV and LA has to pump more forcefully to bypass that obstruction. There is more resistance offered to the blood which is coming from the left atrium into the left ventricle. There could be a mitral stenosis or some left atrial myxoma, or there is concentric LVH, or there is hypertrophic obstructive cardiomyopathy, or severe aortic stenosis, or something is there, or there is a MR because of MI, and there is back pressure change and blood is going back from LV into LA, and so all these things will dilate the LA, okay. So this is another finding we have picked up. And axis, somebody's told me the axis, no, nobody has told me the axis. So Rohan says there is fibrillation. No Rohan, in fibrillation you will not see, in fibrillation you will not see the P waves. If you are seeing the P waves in the ECG, atrial fibrillation is out. If you are seeing the QRS complexes, ventricular fibrillation is out, okay. Now see, we are very nicely seeing the P waves, P waves. So AF is not there, okay. So after seeing around 100 200 ECGs, you will be masters in this and you will be able to diagnose everything very nicely. How I learned ECGs was when I was doing MD in Christian Medical College, Ludhiana. I did my MBBS also from there, you know. And when I was doing MD, as second year residents, PG students, post on call, we were given ECGs which were done in whole of the hospital to interpret. So one copy used to be given to the patient and second copy this big pile of ECGs post on call, we had to interpret the different intervals, the diagnosis, and we had 4 cardiologists, and they were very nice teachers, and they would check, they would call us, correct our mistakes. So that's the best way to learn, hands-on experience, and that's the best way to learn ECGs. So tell me about blood pressure. No, I don't know the blood pressure, Simarjeet. So see, this is definitely not atrial fibrillation. P waves are there. Okay, heart rate can be looking irregular in many other conditions. In atrial flutter also you can see irregular heart rate. In premature supraventricular complexes, PACs or MAT, heart rate can be irregular. In heart blocks, subtle AV blocks, you will see irregular heartbeats, irregular complexes. So that doesn't mean there is atrial fibrillation. So okay, Amrita, okay, fine, there is a LED, fine. Okay, so to see whether there is P wave or not, look in all the complexes. Sometimes in one lead you will not see the P wave, but if you look in lead 2, you look in lead V1, these are the best leads to comment on P wave. So in V1 we are seeing a negative wave, P wave, so that is left atrial enlargement. So this is LBB with left atrial enlargement. Anything else you have picked up? Anything else? So see the PR interval. So PR interval is more than 5 small squares. Okay, so let us say P wave is starting from here and one full big square is covered. So it is 6 small squares P wave. So that makes it first degree heart block. Okay, so you have to spend time, you have to look at the ECG again and again in your mind. Okay, so in one ECG you can have SA block, you can have atrial fibrillation. In the same ECG you can have SA block, atrial fibrillation with atrial flutter. In the same ECG you can have all these plus AV blocks and first degree, second degree, third degree AV blocks, and you can have VPCs. So and you can also have conduction blocks. So in one patient's ECG you can see all these things: SA block, atrial fibrillation, flutter fibrillation, and AV blocks, and LBB and bifascicular block. Now in this ECG there is a bifascicular block because there is a first degree AV block and a LBB, so that makes it bifascicular block. So no need to get confused. After some time you will be good in interpreting. Broad notched R wave in V5, yes, so we call it M pattern in V5 V6. Now this is again LBB. Tall R in lead 1, straight focus goes to lead 1, 0 degree, axis is around -30, -40 or 10 or 20, something like that. To determine whether it is going to the left axis zone or the normal axis zone, you have to look in AVF. AVF is negative, so this is AVF. AVF is totally negative, so plotted at -90. Now then this is a left axis deviation. So this is LBB again, and you can see this is a complete LBB, broad QRS, left axis deviation. Okay, so now we come to right bundle branch block. Right bundle branch block is opposite of LBB. So there will be tall R in V1, V2, deep S in V5, V6. Okay, and in V1 you will see R, S, R dash pattern. So first R is small and second R is big. So that is R, S, R dash pattern. So now see in right bundle branch block. So in this ECG, so there is a RS, RS pattern, and RS, R dash pattern, concavity upwards, ST depression and T wave inversion, and there is a right axis deviation. This is isoelectric lead 1. So perpendicular to lead 1 is AVF. Now see, if some lead is perpendicular, if some lead is isoelectric where R equals to S, then the axis is perpendicular to it. So lead 1 is isoelectric and AVF is perpendicular to it. So you are getting a plus 90 degree axis. So there is a right axis deviation because there is a right bundle branch block and there is a tall R in V1, V2. Okay. Now can anybody ask me any question in this ECG which is contradicting the criteria of right bundle branch block. So, I said in LBB tall R in V5 V6, deep S in V1 V2, RBB tall R in V1 V2, deep S in V5 V6, and broad QRS, and in RBB there is RAD, in LBB there is LAD. So, can anybody tell me what is the problem in this ECG? Amartya, Deleshwar, Indu, anybody, or I will tell. So, I think there is a lot of delay also in the network, so that is why the replies are delayed. Okay, so now see, now there is no S wave in V5 V6. Okay, so this could mean something. This could mean maybe after some time this patient might develop tall R in V5 V6. Yes. Okay, so this patient might be having a left ventricular hypertrophy. Okay, so this patient has probably left ventricular hypertrophy, and we are not getting the full criteria of LVH because there is a RBB. So, like that you have to think. Very good. So, this was Indu. Very good. Okay. So, ideally there should be a deep S. So, this R wave is dominating and small s is there. So, that is something which is not expected in RBB. Good. Now, this is another example of RBB. So, look at the axis, lead 1 is positive and AVF is also positive. So, this is not there is no axis deviation, there is no RAD. Okay. So, right here there is no RAD. Okay, I do not know why I put this ECG, maybe I wanted to show you something. So, this is lead 1 is positive, S is small, R is big, taller than S. Okay, so, lead 1 is positive, definitely positive, and AVF is also sort of positive only. Okay, so, axis is within the normal zone. Okay, so, there is no right axis deviation. I do not know why I have labeled, we will go forward and see. That is why ECG is very interesting. Now, see, in V1 there is RS R dash pattern. Okay. So, and there is a ST depression T wave inversion, and this is right bundle branch block, rabbits here. Okay. So, that is why I labeled it as RBB, but the axis deviation is not there. Maybe there is a hidden some axis deviation cause, again maybe LVH is there which is overpowering the right bundle branch block. Okay. Now, you should have asked me, sir, why RS R dash are formed. Now, again you remember that circle. Okay. So, remember that circle. So, first thing to get depolarized in the ventricles is interventricular septum. Okay. So, in V1, so what is happening, current is coming towards V1 because V1 V2 are here, interventricular septum is here, V1 V2, from left to right it is depolarizing the interventricular septum, V1 V2 record a small r. So, V1 V2 record this r. Okay. Then S wave. So, there is a right bundle branch block, then the current has to because there is a right bundle branch block. So, the left bundle branch is stimulating the right ventricle. So, then there is a small S wave and then the left ventricle gets depolarized. Okay. So, this is why there is a RS R dash pattern. Then there is a LAHB, left anterior hemiblock. So, in that you will see there is a left axis deviation, narrow QRS and deep S in lead 2 and lead 3 and increased VAT. So, this is a good ECG. So, for a LAD to happen, current has to go towards lead 1. So, there has to be good tall R. So, you see there is a tall R in lead 1, there is no S wave. So, R is totally positive. Okay. So, look in AVF, where is AVF? So, AVF is negative, R is very small and S is very deep. Yes, Abhishek, if there is a RS R dash pattern, you may call it as incomplete RBB. Okay. And incomplete RBB, many times you will see the axis won't be deviated, but there is a RS R dash pattern, and QRS might be narrow also, it might not be broad. So that is incomplete RBB. There are aberrations, and it's a challenge sometimes to make a diagnosis. So see, lead 1 is positive in LAHB, okay, lead 1 is positive, AVF is negative. So this guy has recorded as small r and S, which is very nice, okay. Then whenever there is a left axis deviation, you have to think that 99% of the times there is LAHB. So there will be deep S in lead 2 and lead 3. So out here you see deep S in lead 2, lead 3 and a LAD, okay. And there is an increased ventricular activation time. So LAD is has formed, and the R wave is looking like this. The upstroke is more at a tangent, okay. So that is LAHB. Now next question is, why in left anterior hemiblock the QRS is not broad? Because it is not from one chamber to the other chamber. The left anterior fascicle is blocked, the left posterior fascicle will send the current towards lead 1. So there is no time delay. So QRS is not broad. Similarly, left posterior fascicle, QRS is not broad. Amritpal, what about BP? I didn't get you. Okay. Now this again ECG. So you see there is tall R in lead 1, axis around 0 degree, maybe minus 30, minus 40, plus 10, plus 20. Let's look in AVF. AVF is deep S, okay. So there is a left axis deviation. Left axis deviation, 99% of the times in LAD there is left anterior hemiblock. The QRS will not be broad. Then you turn your attention to lead 2 and lead 3. There we will see deep S wave in lead 2 and lead 3. So that is a criteria for LAHB. So what else you see in this ECG? So you have seen the rate rhythm is okay, axis is LAD, and then you look at the P waves, okay, the shape and the contour. Now in V1 P wave is upright. So there is probably maybe a lung pathology is there. It has overpowered the left atrial component out here. P is upright. Usually there will be biphasic P wave in V1. So you should do a chest X-ray, do spirometry, maybe CT chest you should do, and do the echo, look at the pulmonary artery pressures, things like that. That is how you should be thinking. Then out here you see there is a RS complex. This is not a Q wave, this is a R wave. This looks like a Q wave. This is definitely a Q wave. This is a R wave, okay, and this is a junctional beat. So it's coming little prematurely. So R wave amplitude progression is not good. V1, V2, V3, V4, V5. See, R waves are not progressing so nicely. So this is anterior wall MI, old anterior wall MI, old anterior wall ischemia. So that is how I will interpret this ECG. Okay. So this ECG has anterior wall ischemia or old anterior MI with LAHB, and maybe there is a left atrial enlargement, right atrial enlargement, because P is upright in V1. So all these things you will see. Now let us look at the inferior leads, lead 2, lead 3 and lead AVF. See, R wave is not good in these also, but that must be because of the electrical aberration. So now we come to left posterior fascicular block. This is the last for today's. So left posterior fascicular block is basically a diagnosis by exclusion. Okay. So because in left posterior fascicular block you block the left posterior fascicle, then left anterior fascicle will stimulate the left ventricle, that area, inferior medially area. Okay. But it's not going from one chamber to the other. So QRS is not broad, but there is a right axis deviation. So you have to rule out all the causes which is causing right axis deviation, like right ventricular hypertrophy, right bundle branch block, pulmonary embolism, pacemaker at the apex, okay, anterior wall MI. So they can all cause right axis deviation. Sorry, anterior MI, yes, right axis deviation. So you have to rule out all these, and then you can say there is a LPFP, and that is the cause of right axis deviation. So it's a diagnosis by exclusion. So in the end, you remember, left sided blocks, they will dominate the electrical activity of the ECG, and they will signify a serious heart disease. Probably this patient who has developed LAHB, or more seriously left bundle branch block, probably he is having a severe CAD and has all three coronaries blocked, and he might have MI. So you have to do a coronary angiogram on him and monitor him nicely, and always look for occult signs of MI hidden in LBB pattern, concordant T wave. Sometimes, let us say your patient has a LBB and T is inverted in V5 V6. You are seeing him in the OPD, and every month you do an ECG, or 6 monthly you are doing an ECG. Then an ECG is same, you are giving the medicines. Then this patient comes and he doesn't even have chest pain. He is a diabetic. Diabetic patients won't have chest pain. You do the ECG, but T is upright in V5 V6, and there is a LBB. So this is called pseudo normalization of T, or concordant T wave. Okay. So that means the electrical vector has changed. The inverted T has again become upright, and that is because of MI. Do the trop T, it will come positive. Okay. So it is always important. The take home message is, it is always important to look at all the ECGs in serial order. First ECG date wise, second ECG, third ECG, fourth ECG, and you may repeat more ECGs if you want. So we'll stop here, guys, and this next topic we'll discuss tomorrow or whenever we'll see. And thank you so much for coming and listening to the talk, and it makes my day when I see a lot of students are interested in learning. So then we get motivated to prepare more lectures. So this will be lecture for tomorrow, and if there are any queries, you can WhatsApp me. You have my number 7432001215, or only WhatsApp text, no calls please. Okay. And or you can post in the comments box, live comments you can post for some time. I'll keep the comments on for some time, 5 minutes or something, and or in the offline comments you can post, and I will reply. Thank you so much. Bye bye. Stay fit, stay healthy, keep reading. God bless. Bye bye.